Welcome back to the Deep Dive. I'm your host, and today we are doing something a little bit different.
Yeah, this is a fun one.
Usually, we're parsing through these polished academic articles, maybe a hefty book chapter, or a series of well-edited news reports.
The finished product.
Exactly.
Yeah.
But today we are basically playing detective.
We really are. It's a fascinating change of pace. Instead of that finished product, we are looking at the raw materials of learning.
And when I say raw, I mean we have a stack of source material that is literally raw. I'm talking about handwritten notes, scribbles, arrows pointing down, things circled in this heavy, dark ink, fragments of sentences that just kind of trail off.
Yeah.
It looks like the frantic, high-stakes checklist of someone who is trying to memorize how to save a life.
Or, how to pass a really, really hard exam.
Maybe 5 minutes before they actually have to do it.
That is exactly the vibe. These documents, they're titled Chapter 50, Liver. And judging by the content, the urgency, the specific warnings, these little procedure cheats, these have to be student notes.
Right. A nursing student, maybe a med student?
I think so. And they aren't just facts on a page. They're a window into the mind of someone learning how to manage a body that is, for lack of a better term, chemically collapsing.
That's a heavy way to put it, chemically collapsing. But honestly, looking at these scribbles, I mean, words like unresponsive, suction, and my favorite, blows up in. It feels heavy.
It is heavy.
So what's our mission today? What are we doing with this?
Our mission is to decode these notes. We're going to take these fragments, all these little pieces, and reconstruct the clinical picture they represent.
Okay.
But more importantly, because we know our listener today is really looking for that test prep edge, we're going to frame this exactly how a student needs to understand it.
I see.
We aren't just, casually chatting about liver failure. We are identifying the must-know concepts, the things that will absolutely be on the exam.
I love that. So this is not just a story, it's a study guide.
It is the ultimate study guide. We're going to use these notes to understand the crisis management of liver failure. Because when the liver goes, it's not just one organ failing.
It's just the whole system.
It's the entire ecosystem of the body shutting down.
Okay, let's unpack this. The theme here, it really seems to be a balancing act, a very delicate one.
Precisely. The liver is the body's chemical factory. Think of it that way. It filters toxins. It manages fluids. It creates the glue that clots your blood.
Right.
When it shuts down, and the notes mention the word cirrhosis, meaning cirrhosis,
Yeah.
you lose all of those functions.
So these notes are a map of that chaos.
That's a great way to put it. It's a map. We see a patient who is teetering on the edge, where a simple meal, and I mean literally just eating a steak or even the glass of water, can drastically change their status from awake to comatose.
That is terrifying, just
Yeah.
the fragility of it.
It is.
Let's jump right into the first section of these notes, which I'm calling The Brain in Fog.
A very appropriate title. And for anyone preparing for an exam, this is often the biggest section on the test, hepatic encephalopathy.
Right. So at the top of the page, we have some really alarming scribbles. We see mental changes, unresponsive, and a phrase that looks like level of conscientious.
Laughing slightly. The spelling is a bit creative.
Yeah, spelled creatively, but clearly referring to consciousness. And then there's this big arrow pointing straight to ammonia levels.
And that's it. That is the first major concept the student is trying to drill into their head. When we think of liver failure, we naturally think of the abdomen, right? The swelling, the pain.
Of course.
But the most immediate, the most frightening sign is often in the brain. The student has linked mental changes directly to ammonia. That's not an accident.
Okay, so talk me through that. Why the ammonia? Walk us through the biology there.
Okay, so here's the physiology you absolutely need to understand for any test. When your body breaks down protein, doesn't matter if it's from the chicken you ate or from your own muscle cells, it produces ammonia as a waste product.
And ammonia is bad.
Ammonia is toxic. It's a neurotoxin. Normally, a healthy liver just scoops up that ammonia from the blood and converts it into something called urea.
Which is safe.
Totally safe. You just pee it out. It's the body's waste management system, and it works perfectly.
But in our Chapter 50 scenario,
The factory is broken. The liver is cirrhotic. It's scarred. It cannot perform that conversion. It just can't keep up.
so the ammonia just builds up.
It builds up in the blood. And here is the kicker, and this is the direct reason for the mental changes. Ammonia can cross the blood-brain barrier.
Oh, wow. So it literally gets into the brain and poisons it.
It does. It causes what we call hepatic encephalopathy. That's the big clinical term for the mental changes the student noted down.
Encephalopathy meaning brain disease.
Exactly. And it's a spectrum. It starts as maybe just mild confusion, maybe they're acting a little weird, sleep disturbances, forgetting things.
But the notes have unresponsive in all caps.
Right, because as those ammonia levels climb higher and higher, it can progress all the way to a deep coma. And that's the danger.
This connects directly to another note I found really, really interesting. There's a specific diet instruction here. It says, high-protein diet will increase ammonia levels, and then needs V down arrow protein diet.
That down arrow is critical.
Yeah.
For any student, that's a huge red flag to pay attention to.
Wait a second. Usually when someone is sick, what do we tell them? We tell them to eat protein.
Right. Build up your strength.
Heal your tissues, recover. This feels completely backwards.
And that is what we call the protein paradox of liver failure. In almost any other recovery scenario you can imagine, protein is your friend. But here,
It's the enemy.
protein is the raw material for the poison. If you feed a patient who has liver failure a giant steak, you are handing their body a massive load of nitrogen,
Which turns into ammonia.
which turns right into ammonia, which the damaged liver cannot filter.
So you're literally just pouring fuel on the fire.
Exactly. You are directly raising the toxin level in their blood. The notes are highlighting a high-protein diet as a danger. It says explicitly, it will increase ammonia.
So on a test, if you get a question,
If you get a test question that asks about the diet for a patient with hepatic encephalopathy, so confusion due to liver failure, the answer is almost always to restrict protein.
you have to cut off the source of the toxin.
You have to limit the source of the toxin to save the brain, the direct cause and effect.
Okay, this is making sense. So we have a confused patient, their brain is swimming in ammonia, and we are cutting their protein intake. But the notes have another safety warning right next to that unresponsive note. It says suction in room and NG in.
This is the detective work part I love about these notes.
Yeah.
It's not just a fact, it's a plan. Why would you need suction equipment ready for a liver patient?
Right, they're not having lung surgery. So my guess would be, if they're unresponsive, they can't protect their own airway. They can't cough or swallow properly.
Bullseye. That's it, 100%.
Yeah.
If this patient spirals into a coma because their ammonia is too high, or even if they just get very confused and lethargic, their gag reflex might disappear.
Oh.
So if they vomit, which is very common because their whole GI tract is struggling, they could inhale that vomit into their lungs.
That's aspiration.
That's aspiration pneumonia. And that can be fatal.
So it's not even the liver that gets them, it's a complication.
It's often the thing that kills them before the liver failure itself does.
Hmm.
So the student wrote, suction in room as a critical reminder. Be prepared for the worst case scenario.
Don't go running down the hall for the suction machine when the patient starts gurgling.
Have it there, have it plugged in, be ready. The NG in refers to a nasogastric tube.
Okay, what's the role of the NG tube here? What's that for?
It could be for a couple of things.
Mm.
One, you might need it to decompress the stomach if
Yeah.
they are nauseous and vomiting. Just get everything out. But two, and this bridges us perfectly to our next section, you might need it to give them medication if they're too confused or too lethargic to swallow pills.
Right, because if ammonia is the villain of this story, surely we have a weapon to fight it.
We do, and the notes are very, very specific about it. This brings us to section 2, the ammonia trap.
I like that name, the ammonia trap.
Hmm.
And the notes have a scribble here that says, make sure getting lactulose. And then another one of Telius if they are still using, which I think implies checking the active order or if it's still effective.
Lactulose. It is the absolute gold standard. You cannot talk about liver failure,
Yeah.
and you certainly cannot pass an exam on it without understanding what lactulose does.
Okay, it sounds like a sugar. Is it a type of sugar?
It is. It's a synthetic sugar. But your body can't digest it. It passes right through to the colon. And here's the mechanism you need to know. Lactulose works in the gut to lower the pH.
It makes the intestines more acidic.
Yes.
Okay, I feel a chemistry class flashback coming on. Why do we want an acidic gut? What does that do?
Because ammonia is drawn to acid. It's a basic molecule, so it's attracted to an acidic environment. When the gut becomes acidic from the lactulose, ammonia moves from the blood into the gut.
Because it pulls it out of the bloodstream.
It pulls it out. But that's only step one. Once the ammonia is in the gut, the acid works on it and converts the ammonia, which is NH3, into ammonium, which is NH4 plus Mia.
That sounds like a really minor technicality, one hydrogen atom.
It sounds like it, but it's the difference between life and death.
Yeah.
Genuinely. Ammonia, the NH3, can move back and forth across the gut wall into the blood. But ammonium, the NH4 plus Me, is trapped. It has an ionic charge, can cross the intestinal wall.
Just stuck.
It's stuck in the gut. You've trapped the toxin.
So we trap the toxin in the gut. Now what? We can't just leave it there.
Then we flush it out. Lactulose is also a very effective osmotic laxative.
Ah, I see where this is going now.
The note right below the word lactulose says, monitor stools.
I have to admit, when I first read that, I just thought it was, standard hospital procedure. Go to the bathroom today. Kind of checking.
In this specific context, it is so much more than that. Monitor stools is how you measure the dose of the medication. It's how you titrate it.
What do you mean?
The goal of lactulose therapy is usually 2 to 3 soft stools per day. If the patient isn't having any bowel movements,
Then the trap isn't emptying.
the trap isn't emptying, the ammonia is just sitting in their gut. It's not leaving the body.
Mm-hmm.
So constipation for a patient with high ammonia is a medical emergency.
Wow.
On the flip side, if they're having, watery diarrhea 10 times a day, you're probably overdosing them. You're causing dehydration, electrolyte problems.
So that little note, monitor stools, is actually the instruction manual for the most important medication they're on.
It is the titration guide. It tells you if you're giving too much, too little, or just the right amount.
And looking at that Telius note again, that check if they're still using note, it implies checking if it's working. How do we know if it's actually working?
We look at the patient's brain.
It all comes back to the brain.
It always comes back to the brain. The notes link mental changes directly to ammonia.
Mm-hmm.
So if the lactulose is working, what should happen?
The patient should become less confused.
They should wake up. Their confusion should clear. Their handwriting might improve. That is the ultimate metric of success. The stool count is the mechanism, but the mental status is the outcome.
Okay, so we are battling the brain fog with a low-protein diet and carefully monitored laxatives. But now we have to talk about the other massive issue in these notes, the fluid.
Yes, the fluid crisis. This is the visual hallmark of liver failure.
Yeah.
This is what people picture.
The notes have the word asites, spelled A-S-I-T-E-S, circled several times, and there are other references to settle fluid and edema.
Ascites. That is the medical term for a massive accumulation of fluid in the peritoneal cavity, basically, in the abdomen.
Why does it happen? Where is all that fluid coming from?
Well, remember how we said the liver is scarred? That's cirrhosis. All that scar tissue makes the liver hard and dense, so blood can't flow through it easily. It's like a traffic jam. The blood backs up in the veins leading to the liver.
So like a kink in a hose.
It's a perfect analogy. The pressure builds and builds in those veins, specifically the big one called the portal vein. And that pressure gets so high that fluid, the watery part of the blood, literally leaks out of the veins and into the open space of the abdomen.
It just weeps out.
It just weeps out. This is why these patients often look like they're 9 months pregnant, even if their arms and legs are wasting away from muscle loss.
The notes really paint that picture of a patient just retaining massive amounts of fluid. And the student has written down a treatment cycle. It involves diuretics and IV albumin.
Right. Diuretics like Lasix or spironolactone, that's step 1. They help the kidneys pee out excess salt and water. That's pretty standard for any kind of fluid overload.
But the IV albumin is the one that seems more complicated.
It is. And the student has picked up on the most important complication. There is a very specific, almost paradoxical warning in the notes.
I see it. It says IV albumin, and then there's an arrow pointing to a warning. Could cause fluid overload.
This is a classic test question trap, and the student identified it perfectly.
Okay, explain that to me. It makes no sense on the surface. We are giving a treatment for a fluid problem that can cause a fluid problem.
It sounds crazy, but here's the mechanics. Albumin is a protein that normally floats around in your blood. It's made by the liver, and it acts like a sponge.
A sponge.
It has what we call oncotic pressure. It holds water inside the blood vessels so it doesn't leak out. Now, these liver patients, their broken factory isn't making enough albumin.
So their blood is less spongy.
Exactly. That's another reason the fluid leaks out into their belly and their legs.
Okay, so we give them IV albumin to replace the sponge, to make the blood more spongy again.
Right. And here's where it gets tricky. When you infuse that bottle of IV albumin, it's a super concentrated sponge. It suddenly starts pulling all that settled fluid from the tissues, from the belly, back into the blood vessels.
That sounds good. That's what we want.
It is what we want, unless you pull too much fluid back too quickly. Think about it. If you have 5 liters of fluid in your belly, and it all suddenly rushes back into your bloodstream,
The heart has to pump all that.
the heart has to pump it. And if the heart is already weak, or if the volume is just too massive, the heart gets overwhelmed. You can't keep up.
And that's the overload.
That's the fluid overload. And where does fluid go when the heart fails to pump it forward?
It backs up.
It backed up into the lungs.
Which brings us to this other scribble command right next to the albumin note. Check breath sounds.
Yes, the note says, sometime albumin gave check breath sounds. The grammar is a little broken, but the clinical logic is absolutely flawless.
The student is reminding themselves.
If I give this bottle of albumin, I have to put my stethoscope on the patient's lungs before, during, and after the infusion.
What are they listening for specifically?
Crackles. Wet sounds. It sounds like Velcro being pulled apart. That indicates pulmonary edema fluid filling up the air sacs in the lungs.
And if you hear that,
You stop the infusion immediately. You have, in effect, started to drown the patient in their own fluids by trying to treat their ascites.
wow, it's an incredible tightrope walk.
It really is. You need the albumin to pull the fluid out of the belly, but you risk flooding the lungs in the process. This is why the notes are so obsessive about monitoring every little detail.
And speaking of monitoring, there's another metric here that's circled heavily: daily weights and way before and after.
Weight is king in fluid management. The notes say look at IO, which is intake and output, but they really emphasize daily weights
Why is weight so much better than just looking at the swelling or measuring their belly?
because our eyes can be deceived. Swelling can shift around. A patient can look less swollen in their legs, but have more fluid in their abdomen. But mass is mass.
Okay.
1 liter of fluid weighs exactly 1 kilogram, which is 2.2 pounds. There's no ambiguity. If a patient gains 2 pounds overnight, that is not fat.
That's a liter of fluid they're holding on to.
That is 1 liter of fluid retention. That's a huge amount for one day.
So it's the most accurate, sensitive indicator.
It's the most sensitive indicator of whether your diuretics and your fluid restrictions are actually working. If the weight is going up, the patient is getting worse no matter what they look like. The student notes daily weights, because that is the daily scorecard for survival.
So let's say the diuretics and the albumin aren't enough. The belly is just too full, they can't breathe. The notes mention a procedure cheat 1.
This takes us right into section 4, the paracentesis.
Paracentesis, and that's physically draining the fluid, right, with a needle.
Yes, taking a large bore needle or a catheter, inserting it directly into the abdominal cavity, and draining off all that ascites fluid.
The notes have a little checklist here for the procedure. First up, consent done.
Absolutely crucial.
Yeah.
And a key point for any exam. This is an invasive procedure. You are sticking a needle into a belly that is full of fluid, yes, but also contains the intestines, the bladder, other organs.
So there are risks.
Huge risks. You could perforate the bowel. You could hit a blood vessel. The patient has to understand this, so consent is number 1.
And number 2 on the cheat sheet, again, with the way before and after.
This time it's to measure success. If you drain 4 liters of fluid, the patient should instantly be about 4 kilograms, or almost 9 pounds, lighter. It's a direct confirmation of exactly how much fluid you removed.
Now, there is a phrase here that I found very vivid. I have to ask you about it. The student wrote,
Done a bedside 1 blows up in?
yes, blows up in.
What on earth does that mean? Did something explode? It sounds dramatic.
No, nothing exploded. This is clearly student slang, or maybe just a shorthand observation that's stuck in their head.
So what is it?
When you do a paracentesis, especially for large volumes, you don't just let it drip into a bag. You often use vacuum bottles. They're big glass bottles with a strong vacuum seal.
Okay.
When you hook the tubing up to the needle in the patient's belly and then spike the bottle, that vacuum sucks the fluid out with a lot of force.
I see. It's a very visual, very audible process. The yellow fluid literally hisses and rushes into the bottle. I suspect blows up in. Is their description of the vacuum containers filling up incredibly rapidly. It's a dramatic procedure to watch. You can drain liters in just minutes.
The notes also mention action bleeding, but then clarify not a massive amount of blood.
This is a key safety check,
Yeah.
and it connects everything back together. Remember, what organ makes your clotting factors?
The liver.
The liver makes prothrombin fibrinogen, all the proteins that help your blood clot when you get a cut.
And our factory is broken.
Right. So a patient with end-stage liver failure is a profound bleeding risk. They bruise if you look at them wrong. They bleed easily. Now imagine sticking a big needle in their belly.
You're terrified of hitting a blood vessel.
Absolutely terrified, because they might not be able to stop bleeding. So the student is making a note to distinguish between what's expected and what's an emergency.
So action bleeding is what they call the minor stuff.
I think so. A little pink-tinged fluid from the puncture site might be okay. But if the fluid in the bottle suddenly turns bright red, Or if the dressing on their abdomen soaks through with blood, that's a catastrophe. The student is distinguishing between expected minor oozing and a major hemorrhage.
This bleeds pun absolutely intended into our next section, protecting the fragile system.
Yes, and fragile is the right word. The fragility of these patients just cannot be overstated.
The notes have a very clear directive here. Try to protect them from trauma.
This goes right back to the clotting issue. Trauma here doesn't just mean, a car accident or a major fall.
What does it mean then?
It means bumping their arm into the side table and getting a massive hematoma. It means shaving with a razor blade and getting a cut that won't stop bleeding. It even means brushing their teeth too hard.
Really? A toothbrush can be a danger.
Oh, absolutely.
Mm.
If their platelet count is low and their clotting factors are gone, vigorous toothbrushing can cause their gums to bleed, and that bleeding might not stop. We teach students to tell patients to use soft bristle brushes.
So it's all about minimizing risk.
All about it. We use electric razors instead of blades. We keep the bed in the lowest position, as the notes say, make sure bed in position. So if they fall, and remember, they're confused from the ammonia, so they might try to get up, they don't fall as far.
It's a full-spectrum defense strategy. You're protecting the brain from ammonia, the lungs from fluid, and now the skin and gums from trauma.
Exactly. And there is one more critical layer of protection mentioned in the notes. Make sure all meds go through primary care.
Yeah, I saw that. And right next to it, make sure the Talon vitamins. I think that might mean taking vitamins or maybe specifically thiamine.
Thiamine is very likely, especially if alcohol is involved in their liver failure. But that first point, the meds go through primary care point, is huge. This is all about avoiding hepatotoxicity.
Toxicity to the liver.
Yes. The liver metabolizes most drugs, Tylenol, which is acetaminophen, sedatives, narcotics, even some herbal supplements. If the liver is already damaged and barely hanging on, a normal dose of Tylenol could be the final nail in the coffin.
It could push them over the edge.
It could push them into fulminant or acute liver failure. So the student is reminding themselves, don't just give a pill because the patient has a headache or can't sleep.
Check everything.
You are the gatekeeper. Nothing enters that patient's body unless you are 100% sure the liver can handle it.
I want to zoom out for a second. We've been deep in the crisis management, but the notes also hint at how we got here in the first place.
Right, the origin story.
There's a section on hepatitis. It says, hep inflammation of liver caused by contaminated water. If it's not treated, causes cirrhosis.
Cirrhosis, yeah.
Right. It's an interesting little timeline the student has drawn out there.
It is, and it connects the dots beautifully. They're specifically mentioning contaminated water, which points to hepatitis A.
Okay.
Hepatitis A causes an acute inflammation of the liver. Usually your body fights it off and you recover. But the student is making a broader point about inflammation.
If it's not treated.
Right. If you have chronic inflammation, which is more common with hepatitis B, hepatitis C, or chronic alcohol use, that constant inflammation eventually leads to scarring. The body tries to heal itself over and over, and it lays down scar tissue.
And all that scar tissue is cirrhosis.
Yes. Cirrhosis isn't the virus. It's the end result of the damage. It's the scar. And once the liver is scarred, it becomes hard and shrunken. That's what blocks the blood flow, which causes the ascites, and that's what stops the filtering process, which causes the ammonia buildup.
So if we use an analogy, the contaminated water or the virus is the spark, the inflammation is the fire, and cirrhosis is the burnt-down building we're now trying to live in.
That is a perfect analogy. And these notes, the diuretics, the lactulose, the safety checks, that's just us trying to keep the lights on and stop the pipes from bursting in a burnt-down building.
It really puts into perspective how complex this one organ is. You just don't realize how much the liver is doing in the background until it stops.
It manages your fuel, your waste, your blood flow, your clotting, your immune system. When it fails, everything starts to fail.
I want to circle back to one specific detail in the notes that I think really summarizes this whole student mindset we've been talking about. The note Procedure Cheat 1.
Yes, I love that one.
It implies there are other cheats, maybe Procedure Cheat 2 is for something else, but it also suggests that there's a standard official way of doing things that is too long or complex to memorize under pressure.
Medicine is overwhelming. There's so much to know. Procedure Cheat 1 is the student taking a 20-page textbook chapter on paracentesis and boiling it down to the 3 things that will actually save the patient at the bedside.
Consent, weight, safety.
That's it. Consent, weight, safety. The textbook explains the pathophysiology of portal hypertension, which is great to know. But at 3 in the morning, when the patient is struggling to breathe because their belly is so full of fluid, you need the cheat sheet.
You need the action item.
You need to know. Did they sign the paper? Did we weigh them? Is the suction ready just in case? Is the bleeding risk assessed? That's what matters.
It's practical knowledge versus theoretical knowledge.
And that is what this whole deep dive has been about. These notes are the bridge between the textbook theory and the messy reality of clinical practice.
So let's review the deep dive journey we've taken through these scribbles, just to tie it all together for anyone studying.
Let's do it. We started with the brain, the mental changes, and the unresponsive notes.
And we learned that ammonia is the culprit, protein in the diet is the fuel for it, and lactulose is the trap we use to get it out.
Then we moved to the belly, the ascites, and the settle fluid. We learned about that delicate balance of giving AV albumin to pull fluid back into the vessels.
But always checking breath sounds to make sure we don't accidentally drown the lungs.
Then we talked about the procedure cheat, the paracentesis, weighing before and after to track the fluid loss and watching carefully for that action bleeding.
Right, distinguishing a little ooze from a major hemorrhage.
And finally, that overarching theme of safety, protect from trauma. No razor blades, soft toothbrushes, and carefully vetting every single medication, because the whole system is fragile.
Ideally, for the learner listening to this, what is the single biggest takeaway? If they're staring at a test question or, a real patient, what's the anchor concept?
The anchor is connection. Don't just memorize these facts in isolation. That's what separates a good student from a great one. You have to connect the dots.
How so?
Connect the high ammonia to the low protein diet. Connect the IV albumin to the lung sounds. Connect the bleeding risk from the paracentesis to the fact that the liver makes clotting factors. The student notes are messy, but that's what they're trying to do, draw these lines.
So if you see confusion on an exam,
think ammonia and lactulose if you see ascites.
think albumin, breath sounds, and daily weights.
Exactly. It's all one big chain reaction.
It's an ecosystem.
A failing ecosystem, for sure, but an ecosystem nonetheless.
As we wrap up, what strikes me most is the final provocative thought that comes out of all this. We have all these clever interventions. We have the lactulose, the low protein, the albumin. But the notes, when you read them all together, they really capture a fundamental paradox.
Which one are you thinking of?
To save the brain from ammonia, we have to starve the body of protein. Low protein diet. So the body is literally wasting away, their muscles are atrophying, but we can't give them the one thing that would build them back up.
Right, and to fix the fluid that's pooling in the belly, we give fluids directly into the vein, the albumin, which carries the very real risk of flooding their lungs.
Exactly. It feels like every single solution carries a brand new risk. It's not about fixing the patient in the traditional sense. It feels like it's about managing the decline.
That is the hard, cold truth of end-stage liver disease. You are constantly trading one problem for another, hoping to buy time.
Time for what?
Maybe time for a transplant if they're a candidate. Maybe just time for the family to say goodbye. But you are constantly robbing Peter to pay Paul. Every decision is a calculation of risk versus benefit.
Robbing Peter to pay Paul. That seems like the perfect, slightly tragic summary of Chapter 50.
It is. But as these notes show, if you're vigilant, if you check those breath sounds, if you monitor those stools, if you weigh that patient every single day, you can keep the ledger balanced for a little while longer.
And sometimes that's the goal. To the student who wrote these notes, nice work, you got the important stuff. And to you listening, thanks for taking the plunge with us.
Keep connecting the dots. That's the key.
We'll see you on the next Deep Dive.